Welcome, everyone. We're so glad you're here with us, taking time out of your evening to have a discussion with us about menopause. So we're going to go ahead and get started. Our talk is called Let's Talk Menopause. I'm going to introduce myself, and then I'll let Dr. Sarah Horvath introduce herself. I'm Cynthia Chuang. I'm a general internist here at Penn State, Hershey. I'm professor of medicine, public health sciences, and obstetrics and gynecology. I've been here in Hershey for over 20 years now as a primary care physician. And this year I started our virtual menopause clinic program, which you'll hear a little bit about today. And I am a Menopause Society certified practitioner. Dr. Horvath?
Hi, everyone. Thanks so much for coming and joining us. I'm Sarah Horvath. I am double board certified in obstetrics and gynecology and complex family planning, which means I love thinking about contraception and hormones by extension. And I'm here supporting Dr. Chuang in her new menopause specific clinic. But we also recognize that some patients will need more specialized obstetric care as part of that care. And so I'm here to support that piece of everything.
So this is what we're going to talk about today. We're going to talk about what is menopause and perimenopause. We're going to talk about some common myths regarding menopause that we think we can shed some light on, and talk about how to find out if you are a candidate for menopause therapy. However, Dr. Horvath and I are presenting some general information about menopause. Obviously, we can't provide any specific medical advice today. Okay, so let's get started. What is menopause and perimenopause? So menopause is a normal and natural phase of life. It's not a disease. It's a totally normal process. The average age for women to go through menopause is age 51, but there's a large range. 95% of women go through menopause sometime between age 45 and 55. That is the, time that most people go through menopause, natural menopause. There may be other reasons why menopause may be coming at different times. Women who've gotten chemotherapy, women who've had hysterectomy with their ovaries removed, they may have surgical or other medical reasons to have gone through menopause at a different time. We want to say that if menopause is occurring at an earlier age than that, that may need some special attention. So if you're going through menopause before the age of 45, that is considered early menopause. And if you're going through menopause before the age of 40, that's considered premature ovarian insufficiency. And those are different conditions where we need to rule out different kinds of health conditions that may be causing you to have stopped having your period. So if that is the case, that would need a different kind of evaluation. We got a lot of questions from when you guys signed up. A lot of you asked some questions, and boy, did you ask some great questions. There were a lot of people who asked about, well, how do I know if I'm going through menopause if I've had a hysterectomy, or if I have an IUD, or if I've had a uterine ablation? Well, you know what? We probably cannot know exactly when you're going through menopause. So as you see on the slide, menopause is defined as 12 months after you have your final menstrual period. So the important thing to know about that is all you need to know is when you had your final menstrual period and if 12 months has passed, and that is when menopause is. You typically don't need any special tests, no lab tests, no blood tests, no urine tests, no saliva tests, no CAT scans or imaging or anything else. If you have had one of those situations where you've had a hysterectomy or an IUD or an ablation, it's going to be much more difficult to tell when you've gone through menopause, but actually that's okay, because knowing the precise date or the precise month is actually not that important. It's more important to know, okay, if I've had a hysterectomy 10 years ago, I'm somewhere between the age of 45 and 55, so this would have been the typical time that I would have gone through menopause, and I'm starting to have hot flashes. That pretty much tips us off that you're starting this menopause transition. And then, so what is perimenopause? Perimenopause is that time before menopause when people start having irregular periods and they may start having some of the symptoms that we consider to be associated with menopause. So, like those hot flashes. Perimenopause can be super short or can be super long, but the average time period is 4 years.
And I just want to jump in here and say it can be a little bit confusing because during that perimenopause, your cycle lengths may really
Yes.
get a lot longer. And so some people will think like, oh man, it's been like 8 months since I've had my last period. That's it. I'm in menopause. And then you have one more period and you're like, oh, okay. And you kind of have to start that clock over again. And so that's why, this period is definitely a long period of transition and everybody's journey can be a little bit different. But that, remember, as we kind of go through some of these little pearls of things to be thinking about, that you really have to get to that definition of 12 months before you're kind of out of the woods and can stop thinking about all the things you had to think about in your reproductive years.
And even in that early part of perimenopause, some people actually have more frequent periods. They're actually coming closer together. So we commonly hear, oh my gosh, I just finished my period. I feel like they're coming every 3 weeks. They're longer, they're heavier. What's going on? I thought as I got closer to menopause, they'd be lighter and further apart. Well, unfortunately, in the early parts of perimenopause, sometimes it's the opposite. Sometimes they're closer together and heavier. Okay, I'm going to move us forward. So we're going to debunk some myths, Dr. Horvath and I. So Sarah, I'm going to hand it over to you.
All right. So the myths we're going to talk about today are that menopause is just hot flashes. Nope, there are other things. Not everything related to aging is menopause, but there are a whole lot of things other than hot flashes that are associated. And so we're going to talk a little bit about what those things could be. The second big one is that hormone therapy is dangerous, and that's not true. Hormone therapy is the mainstay of menopause and perimenopausal treatment for most people, but we're going to talk about when it's the safest and when it might not be the right thing for you. So we'll talk in broad strokes about that as well. That hormones are the only treatment option? Absolutely not. You don't have to suffer if you either have a reason not to take hormones or if you just would prefer not to. There are other options available and they're tailored specifically to you. 4, we're going to talk about these natural treatments being safer. This is a huge trope right now in social media, and we actually kind of think that the opposite is true, and we'll talk through that as well. And then finally, we're going to talk about people thinking, well, I'm in the perimenopause, I'm 45, I can't get pregnant. That is also not true. So we'll talk in a little bit more detail about all 5 of these myths, and then we'll open it up for some questions at the end. Next slide. Okay, so myth number 1 is that it's just hot flashes. All right, depending on which study you read, it can be up to 81% of folks that actually suffer from hot flashes. So important to recognize that this is the most common sign of menopause, but it's not the only one. Night sweats and difficulty sleeping that may or may not be related to those hot flashes, right? Mood changes, and then vaginal dryness or discomfort. Often you'll hear Dr. Chuang and I talk about the genitourinary syndrome of menopause, or GSM. And that's really, really common. And some of the treatments, if you're only having that, can be a little bit different. Or if you're not having that along with hot flashes, your treatment might be a little bit tailored to which of those things you're actually feeling. And then other things like joint pain or stiffness, memory problems, those urinary symptoms kind of come back and get folded into that GSM again, the genitourinary symptoms of pregnancy, of menopause. Oh my goodness. And then just sort of an other bucket, because people will certainly attribute other things to it. But again, thinking beyond the hot flashes and really figuring out what your specific sort of suite of symptoms might be so that we can tailor treatments to the individual.
One of the things we noticed is a lot of people had questions when they registered about weight gain, and you may notice that weight gain is not on this slide. So they've done studies to look at what is the association between weight gain and menopause, and certainly women gain weight during midlife. When you look across the population, women gain weight in midlife. However, it looks like that is probably more age-related and not necessarily specific hormone-related or menopause-related. So when they look at when women transition through menopause at somewhat different ages, or women who don't go through menopause or go through surgical menopause, that it seems like the weight gain is related to age and not so much due to menopause transition. So that can be a difficult challenge for many people. Okay, so I'm going to move us to the next slide. So the second myth we wanted to talk about was the belief that hormone therapy is dangerous. And it is no wonder that people believe this when you look back at the history of hormone therapy. So this graph here, it's kind of an interesting historical look at how often hormone therapy has been prescribed over the years. So hormone therapy for menopause has been around for a long time. It actually got introduced in the 1940s, as you can see here with the blue dot that says 1 in it. That was when it was first introduced. And then what happened is it started to go up, more common, and then it was recognized in the mid 70s. And this is important because well, you'll see why. It was recognized that having estrogen alone for your hormone therapy was associated with an increased risk of uterine cancer or endometrial cancer. And following that, there was a drop in prescriptions, as you can see. And then what happened was that people recognized that if you add the second hormone, a progestogen, to the estrogen, that helps reduce the risk of the endometrial cancer, the uterine cancer. So after the progestogen is added, then we see an increase again in the prescriptions for hormone therapy. We're going to come back to that. So basically, if you have a uterus and we need to protect it against uterine cancer, you need estrogen and progestin for your hormone therapy. If you have had a hysterectomy and don't have a uterus, and we don't need to protect your uterus against uterine cancer, you only need estrogen for your hormone replacement therapy. So we'll talk more about that in a few minutes, but just wanted to point that out. And then we saw an increase again up until the early 2000s. Many of you may be familiar with a really big study called the Women's Health Initiative, where we really learned about some of the risks associated with hormone therapy. We learned that in the Women's Health Initiative, there was an increased risk of breast cancer, increased risk of heart disease, increased risk of stroke. However, what we also understand is that in the Women's Health Initiative, the average age of women starting hormone therapy was in their mid 60s and later. In their mid 60s and later. So those risks are true for women who start hormone therapy in those kind of later stages. But when they went back and looked at those studies really carefully, well, let's talk about the women who start hormone therapy earlier. What about that subset of women? What if you start hormone therapy in your 50s, within 10 years of going through menopause? Is there the same risk? And that's when we learned something called the timing hypothesis, which is that if you start hormone therapy earlier, again, with before the age of 60 and within 10 years of menopause, that it is not associated with the same kind of risk. So a lot of you asked questions very specific about what the actual risk is. So for those of you who are data heavy, I'm giving you a data heavy slide here. This is a really nice graphic that I really like showing my patients. So the top half of the slide is for women who have had a hysterectomy and only need estrogen. So the CEE is an abbreviation for a type of estrogen. So the top half of the slide is the women who've had a hysterectomy and only need estrogen. The bottom half of the slide are for women who still have their uterus, so they need both estrogen and progestin. So what this slide shows is here are all the risks the bad outcomes that we are really worried about and looking for when we prescribe hormone therapy. And what the numbers here show is what what is the number of events for every 10,000 women per year who is on hormone therapy when you're only looking at women who are in their 50s and starting hormone therapy within 10 years of menopause. And as you can see, for the women who don't have a uterus and only need estrogen, the risk is really with these blood clots, deep vein thrombosis and pulmonary embolism. Those are types of blood clots. And we can see for those two things, there's an increased number of women, 5 out of 10,000 per year for this deep vein thrombosis and 3 per 10,000 per year for the pulmonary embolism. But look at all these other things. They're all below the line in the blue. So the women who got the estrogen therapy actually had a lower chance of having heart disease, stroke, breast cancer, colon cancer, all cancers, fractures, death from any cause, and diabetes. So for women who don't have a uterus, they've had a hysterectomy, hormone therapy is actually really, really quite safe. And there's a lot of benefits, although there is a risk of the blood clots. Now let's look down at the bottom half of the slide. These are the women, which is most women, who still have their uterus, and they need both the estrogen and the progesterone. Now you can see that there's more risks here. They also have the increased risk of the blood clots. There's also a small increased risk of coronary heart disease, stroke, and breast cancer. However, the conclusion that the Menopause Society, the American College of Obstetricians and Gynecologists, and the Endocrine Society made was that because these risks are relatively small, at the most is 10 per 10,000 per year, that if a patient is having bothersome symptoms of menopause, hot flashes, night sweats, urinary, vaginal symptoms, that, sharing decision-making with the patient, it can be very safe to use hormone replacement therapy. And again, there are certain benefits too. We think that with overall cancer risk might be lower, fracture risk is lower, diabetes is lower, and death from any cause is lower. So I know that's a lot of data, but I know a lot of you were asking for it. So I think this is a really important slide to kind of keep in mind.
I think two things that are really important here too. The first one is that there was a time in history not so long ago when we thought, well, maybe everybody should just take these. And so that balance of, are we actually treating symptoms versus should I do this just because I'm going through menopause? I think that's one of the frame shifts that's really happened, which is we can tailor what we give you to exactly the thing that you're going through. And if you're not having, if you're in the 20% who aren't having hot flashes, you don't need this therapy, right? So, but there was a time not so long ago when we thought maybe everybody should just do it. So that's part of too why these risks and benefits have yo-yoed over time and why you've seen the recommendations change. And then the other thing that I want to point out, and this is a little thing, but these trials were done about a little more than 10 years ago. And you'll notice that they use the oral progestin. So the trial using like an IUD to deliver your progestin locally hasn't been done yet, but you can hypothesize why maybe if you had locally acting instead of systemic, it might be closer to the top line than the bottom line. But we don't know that. And so certainly the change could be in either direction, but something to think about too, if you're thinking about how you're going to protect that endometrial lining, that we have new and different ways to do that as well, that might, make a third and different graph as well.
Dr. Horvath, I'll also point out that this data is mostly from the Women's Health Initiative. So the estrogen used in these studies, I kind of glossed over this, but the abbreviation CEE, this refers to the oral pill estrogen that was in vogue at the time, which we don't use nearly as much anymore. I'm going to show you on the next slide what we use now. But some of you may remember the CEE, it stands for conjugated equine estrogen. Why equine? Because that estrogen back then, the estrogen that our mothers and grandmothers used was actually isolated from the urine of pregnant horses. So that is not what we use anymore. This product is still available. There are some situations where it may be appropriate, but it's really used much, much less. So I'm going to move to the next slide to show you what estrogen looks like these days. So what is menopausal hormone therapy? The estrogen, it's typically called estradiol, and it's what we almost always use these days is a patch that looks like what you see here on the screen. Estradiol is actually, some of you may have heard of this phrase that's people are saying bioidentical hormones. That was a term that was really a marketing term, but what I think it's meant to mean is that it is the form of hormone that is identical to what is naturally occurring in our bodies. So estradiol is the naturally occurring hormone form in our bodies for estrogen. So the patch is made with estradiol, and it is usually switched twice a week. There's a form of the patch that's also a weekly patch, but most people use the twice weekly patch. Not everyone likes the patch. Some people find that for whatever reason, they don't like it. Some people have adhesive allergies. They find it irritating. I find most people really do really well with the patch, but there are some people who don't do well with the patch. So like I said before, their pills are still out there. We can use them. There's actually also a gel that you squirt on your arm and you rub in. So that's another option. There's also a spray. You spray on your arm and you rub in. There's also like it looks like a plastic ring that has estrogen in it that you insert in the vagina. So that is another option as well. So that is what you would be using for the estrogen part. Now, we mentioned that if you have a uterus, you also need the progesterone part. So if you have a uterus, you need progesterone. It's typically given as a pill and we usually ask people to take it at bedtime because the main side effect of the progesterone is sleepiness. So a lot of people welcome that as a side effect because they feel like it helps them sleep. Other side effects of progesterone besides the sleepiness is sometimes people get a little bloating. Some people get a little constipation. Typically that's mild. A lot of people say it kind of they get used to it over time or it doesn't bother them over time, but that is a side effect to be aware of. And then as Dr. Horvath alluded to on the last slide, for people who don't want to take the progesterone pill, another option is an IUD that releases progesterone. That's another option too. And one of the advantages to that is there might be fewer side effects with that because we think the progesterone stays more locally in that uterus. I mean, it does get around in your body too, but maybe not as much as the oral pill. Would you agree with that, Dr. Horvath?
Yeah, we actually have studies that show that it's a much lower level than you would have with the pill. So it is systemically absorbed, but in very, very low doses.
And I didn't even talk about the potential side effects with the estrogen. So for those of you who may have been on birth control pills as well, it's the same sort of side effects that we think about with the hormones and birth control pills. So nausea, breast tenderness, those might be potential side effects. But the really interesting thing is that the potency of the estrogen for menopausal hormone therapy is at least 5 times less of what's in the lowest birth control pill. So people generally find the hormone replacement therapy hormones to be much more tolerable and less side effects than they may have found if what they remember from birth control pills. Okay, I'm going to move us to the next slide. So this is really the mainstay of treatment for people who have bothersome hot flashes, bothersome night sweats, bothersome genital urinary symptoms. And it's FDA approved for all those things. It's also FDA approved for osteoporosis prevention. So it's also very appropriate if you wanted to take these if someone wanted to take these medications for osteoporosis prevention. So what about patients who don't have hot flashes, but they're having vaginal symptoms? Dr. Horvath alluded earlier to something called urinary syndrome, genital urinary syndrome of menopause. So what that is when people have changes to the labia, the vagina, the urethra, or their bladder that is due to hormone deficiency, and that can lead to certain symptoms. So The genital symptoms may be vaginal dryness, it may be burning, it may be irritation. Sometimes it's very mild and they only notice it with sexual activity. Other people find it extremely bothersome when they wear jeans, when they wear pants. They find it very irritating and uncomfortable a lot of the time. So this can be very bothersome for a lot of people. The sexual symptoms could be, decreased lubrication, pain with sexual intercourse. Urinary symptoms could be urinary urgency, pain with urination, or having more recurrent UTIs. These are symptoms of the genital urinary syndrome of menopause. The definition of this is not only that you have these symptoms, but that you find them bothersome. And actually 50% of women in postmenopause have genital urinary syndrome of menopause. So it's really common, and only 6 to 7% of those women are being treated. So what are the kind of mainstays, like how do we approach this? Well, the first things to think about are actually really simple that many of us may already be doing, and that is lubricants and moisturizers. So I think of those are two separate things actually. So lubricants are for reducing friction during sexual activity. Those are lubricants, reducing friction for sexual activity. Moisturizers are what they sound like. They're moisturizers. I think of them similar of the way you would think of like using lotion on your skin, actually. So they're for helping retain moisture. They're not for sexual activity. They're for just, regular everyday use. So lubricants, there's cheap and like everything, there's cheap forms of lubricants and there's expensive. You can actually use what is in your kitchen. You can use cooking oil, olive oil. You can use petroleum jelly, which is what is in Vaseline. Those are all appropriate lubricants. However, those are not safe to use with condoms, though. Those can break down the material that's in condoms. So there are commercially available lubricants that are, maybe less messy. They'll be more expensive, but they might be less messy and can be used with condoms. So I know that people are always asking me, so Dr. Horvath, I hope it's okay. I'm going to name a name brand. So I think a common name brand of lubricants that I think people like using for the sexual activity is Uberlube. I think that is a silicone-based lubricant that seems to work very well for a lot of people. Moisturizers are a different thing. Moisturizers are more like lotion, and you could use them every day, but maybe most people use them 2 to 3 times a week to help them retain moisture in the vaginal area. There's also actually physical therapy. There's pelvic floor physical therapy that can help with some of these symptoms. They can help if you have really tight or really weak pelvic floor muscles. And then what you see on the screen here is actually when we get to medications. So the thing on the very left, where it looks like cream, that is actually a low-dose vaginal estrogen cream, where we're delivering a low-dose amount of estrogen to the vagina and the vaginal area. You can get this in the cream form. You can get this thing on the bottom with the blue applicator. That is those are vaginal tablets. Those names you may have heard before are Vagifem, Uvifem. The pink colored things, these are inserts, which are really basically the same thing as the tablets, but they don't come with the applicator. That is very expensive, to be honest with you. And then there's also a ring where that can also deliver the low dose estrogen as well. So there's a lot of options, and there's also non-hormonal options as well that may work better for you as well.
That's a great transition to the next slide. And so the myth number 3 is that hormones are the only treatment option. So hormone therapy is actually not appropriate for folks who've had any kind of breast cancer or any other hormonal cancer. Okay. So if you fall into that bucket, you should not be on hormones. And that includes bioidentical hormones and some of these other things that people are getting outside. Really, really important that you know that you're not a candidate for those things if you have a hormone sensitive cancer. However, there are other things, so don't despair. Again, cardiovascular disease, stroke, or blood clots, whether you've had clots in your legs or your lungs, anytime you've ever had to be treated for something like that. And then if you have just a personal preference, if you're like, you know what, I remember, I really like to avoid hormones. I feel like I've always been super sensitive to them. They're not working for me. That's okay. You don't have to suffer just because you can't or you don't want to take hormones. There are lots of other options. Um, Next slide.
Yeah, and related to that, the slide that I showed earlier with the risks and the benefits, like some people will look at that and be like, well, I don't want there to be any risks. Like I just don't want to be on hormone therapy at all. Like and that is of course perfectly acceptable. Okay, there we go.
And so I think, some people are like, I don't want to be on any medication. So again, there are even non-medication things, right? So if you're like, any risk is too much for me, I don't want to take any medications at all. You can look at this right side of the screen, right? CBT, cognitive behavioral therapy, sometimes doing those kinds of mental health treatments, clinical hypnosis, sometimes weight loss, right? You can imagine if you're having hot flashes and you're carrying some extra weight, losing some weight can also help sometimes with some of that temperature regulation. And then stellate ganglion blocks as well. And I think, Dr. Chuang already talked about pelvic floor PT. We have some really good pelvic floor therapists here. I have sent people to them before. I've never had anyone come back and say they didn't like it. Literally every person I've ever sent for pelvic floor PT has come back and just raved about it. And so I think we have these other non-medical modalities as well. But if you are interested in medications, but not hormones, some antidepressants have actually been studied and shown differences in combating things like hot flashes. So that's generally SSRIs and SNRIs. And then gabapentin, oxybutynin, and you've probably heard about fezolinetant. I was reading my JAMA today, so hot off the presses. There's another medication that's in the same class as the fezolinetant that just went through phase 3 trials. So we're probably going to have another one of those on the market here pretty soon. Those also, though, just like hormones, right? All of these have their own unique risks and benefits to them as well. So it's going to be really important that before you start something, you have a frank discussion about it. Like fezolinetant and alcohol don't really go very well together. So if you're somebody who's like, wow, I like to go have a glass of wine and have a date with my partner before I have sex, and then I'm taking this medication in order, right? You can kind of like see how maybe those two things wouldn't go so well together for you. And so how are we going to find the thing that works the best with your particular lifestyle and the things that are going on? But just understand that, and I think that the world is sort of waking up. I think just looking at how many people are on this call, it shows how the world is really waking up to the fact that this is something that we all go through. And so we need to have better ways of treating it. And so I think my guess is in the next 5 to 10 years, we're going to see even more. So if you're on this call and you're like in your late 30s, hang in there. Maybe by the time you get there, we're going to have even more great stuff for you.
I'll just say, in case you're wondering, what is this fezolinetant? You may have seen commercials for Veoza. That's the brand name for fezolinetant, in case you're wondering why you haven't heard of that one. So what is not, you may notice, so Dr. Horvath got these things on this slide from the Menopause Society's position statement on non-hormonal options. I know you guys are thinking, why are there no supplements on this list? So actually, the Menopause Society came to the conclusion that we should recommend avoiding supplements because there's a lack of proven science for their effectiveness and safety, and there's concerns about regulation and quality. That is not to say that some people are not going to try some supplements and they're going to find them helpful for their symptoms. That may very well be the case. It's just that the Menopause Society's guideline is that there just isn't enough data in order to recommend them based on what's available evidence for effectiveness and safety. So for non-medication treatments, they recommend focusing on the things on the right side of that slide that Dr. Horvath talked about, the cognitive behavioral therapy, hypnosis, lifestyle changes, and then of course the prescription medications. I know that's going to be a disappointment to a lot of people because I know a lot of people had a lot of questions about supplements. So speaking of things that we are wary of, we're going to go to our next slide. And these are some things to think about, to be wary of. Menopause is having a business opportunity right now. And sometimes that's good because it brings attention to health conditions we care about. But sometimes that's bad because it brings people who are looking to make money off of a certain situation. And so there's a lot of commercialization around menopause right now. I can't open my social media without getting all kinds of information about menopause, and I'm sure some of you are finding the same. So if it's too good to be true, like our mom said, it probably is. I think it's important to see who's selling the product. There's a lot of celebrity endorsements out there. I love Oprah. Oprah, I love you, but I don't love what you're doing around menopause. I think there's some, really not scientifically based information that's being promoted by celebrities, and I think we need to be cautious about that. There is a lot of things that are being promoted by physicians as well, and I think I would be cautious about healthcare providers who are not taking insurance and have cash-only businesses. They're selling products where they make a profit. Those are at times, I think, to be cautious. There's a lot of marketing buzzwords out there, hormone balance and imbalance. Those aren't really scientific terms. Those are terms that are having a heyday on social media. There's no such thing as adrenal fatigue. No adrenal fatigue. That's not a scientific medical term, but a lot of people think they have that because of what they're hearing about on social media. Expert recommended, clinically tested. It's unclear what all those things mean. We already talked about caution with dietary supplements. They're unregulated. Compounded bioidentical hormone therapy. I'm just going to take a moment to talk about what that even means. So when Dr. Horvath and I prescribe medications, it's almost always a prescription that goes to, what we think of as a regular pharmacy, like a CVS or a Rite Aid, or, a pharmacy that might be in a grocery store or something like that. Every so often, there are medications that the way they come, it needs to be changed. Like, for example, there might be a pill, but the person really needs a liquid form of it. Or, actually a good example, I forgot to say earlier, this is so important, the progesterone, it's formulated in peanut oil. So for people who have a peanut allergy, they can't take the progesterone the way that it's manufactured. And so that would be an appropriate time to go to a compounded pharmacy and say, hey, I need progesterone that's compounded in a different way that's not in peanut oil. But there are menopause providers who are prescribing hormone therapy through compounding pharmacies that are not the FDA forms of hormone therapy. They're just not regulated. We don't know how much hormone is in those products. We don't know what type of hormones are in those products. And it's not that they might not be safe, but we just don't know exactly what's in them. They're not required to put the warning labels, the black box labels on their products, and there's no mechanism to track any adverse events. So we are cautioning people to avoid compounded bioidentical hormone therapy. Also in that category is something you may have heard of that is called pellets. Pellets are compounded hormone therapy that may contain estrogen, they may contain testosterone, and they are implanted under the skin, and they can't be removed. And they give you a big dose of the hormone therapy, and it kind of wears off over the course usually of about 6 months or so. Sometimes people have adverse effects of those medications, and we can't get them out. And there's been a fair amount of harms that have been associated with pellets, so we do not recommend them either. And then finally, the last thing I have on this slide is salivary and urinary hormone testing is not recommended. Actually, I talked earlier about how, actually most of the time, even regular blood testing is not necessary. We're able to determine that you're in perimenopause or menopause just based on your story alone. What is the pattern of your symptoms? What is the pattern of your periods? And the thing is, when you're in perimenopause, your hormones vary really widely throughout the day and day to day. So if we got blood tests to check your hormone levels today, if I check them again 6 hours later, they could be widely different. So they just don't provide a lot of information. You don't need hormone therapy to diagnose perimenopause or menopause. You don't need hormone therapy to determine if you're responding well to the hormones you're on or anything like that. Certainly no role for salivary or urinary hormone testing. There are providers who are ordering these tests. They cost thousands of dollars out of pocket, and they're not covered by insurance. So beware of that. And someone's making a lot of money off of these things. So for things that are not covered by your insurance, please just be cautious. Okay, Dr. Horvath, our last myth.
Okay, so the last myth is that perimenopausal women can't get pregnant. Until you've gone that full 12 months without having a period, you are still at risk of pregnancy. And as we said, sometimes your periods can get a lot closer together, which means you're ovulating more often, and then they start to lengthen, and now you're ovulating at sort of random times and you're not really sure when it's coming. And so what we know is that because you're still having those escape ovulations, 48%, almost half of pregnancies in women aged 40 to 45 are unintended. And that's higher. We have a high national average in the United States. This is even higher than our high national average in the United States. Okay. So if you're all sitting around, hopefully you're with like a group of girlfriends, you're all sharing a bottle of wine right now and listening to this talk. And what you're doing, if you're looking around at your three friends, is that, 3 out of the 4 of you are still at risk of an unintended pregnancy if you're between the ages of 45 and 50. Okay, so this happens a lot where we have those oops pregnancies well into our 40s. And those pregnancies are clearly higher risk, both for mom and for baby. And so really important to recognize that the pregnancy can happen and making sure that you're protecting yourself from that until you've had your full 12 months without an ovulation, right? So the thing that's good about that is that a lot of the things that we've talked about already can also provide you with protection from pregnancy if you don't want to get pregnant anymore. So that IUD is really highly effective at preventing pregnancy. It's only about a 1 in 500 failure rate if you're using the progestin IUD inside your uterus. So that's a great method. If you're going to use like a patch or a cream or a gel as well. And then combined oral contraceptives, actually, right? So we've talked about this a little bit. Oral contraceptive pills, the ones that you used when you were a teenager, or maybe you're using them right now for pregnancy prevention, they have both estrogen and progestin in them. And we have literally hundreds of them. So as you're getting older, if you're using that method and it's working really well for you, but now you're saying, oh, kind of the things that matter to me have changed a little bit. My symptoms have changed a little bit. Maybe you used to have really heavy periods and now they're getting lighter as you age, or vice versa. We can play with the formulation of that pill and get you one that feels better with whatever symptoms you're having as you go into perimenopause and start to approach menopause, and get you kind of that dual role of pregnancy prevention and also treating some of the symptoms that you're having. So, and again, that tinkering is really individualized. So when you come in, we can say, I've been really happy on my pill, but XYZ changes, and then we can try to play with a different pill for you and get you to that full transition if that's helpful. Next slide.
So our last slide, I'm hoping that we gave you some information that empowers you to talk with whoever your primary provider is, whether that be a primary care provider, whether that be your OB/GYN, whoever you feel most comfortable with. Hopefully we've given you some ideas of how you may approach them and talk about where you are with your periods and where you are with your symptoms. And I've learned about some things that might be helpful to me or that I want to talk about. I want your opinion about whether or not they're helpful. We fully recognize, though, that not all healthcare providers are um, comfortable with managing either hormonal or non-hormonal treatments for menopause. So we wanted to start a different option for people. And so this is our virtual menopause clinic. If you make an appointment, you'll be seeing me. It's all virtual, so you can do it from the comfort of your home or wherever. When a lot of people see me while they're on their break at work, and that works totally fine. You see the number there on the screen. I'm happy to see people in conjunction with whatever your primary providers are doing. We can work in conjunction with them. So keep us in mind for that. And then several of you have expressed interest in whether or not we're doing research here at Penn State College of Medicine around menopause. So one of our colleagues in the Department of Psychiatry, Dr. Dara Babinski, is actually studying basically how your brain changes, like what memory changes, mood changes, attention changes. There's been questions of whether or not there's a connection between increasing symptoms of ADHD as people go through perimenopause and menopause. So she's interested in all these things. So if you think you might be interested in being in a study, please snap the QR code right there. The only thing you need to qualify is being between the ages of 42 and 52, and you've had at least one period in the last 3 months. That's it. If you meet that criteria, she's interested in talking with you, and there is compensation provided for her study. So there's that information. And then we made it to the end of our slides, Dr. Horvath. We are ready for question and answer, but I think I'll need help from Melissa and Megan to figure out how we answer questions here.
Sounds great. I see some hands raised and I saw a few raised throughout. I'm not sure if we're able to unmute people to ask their questions or if they have to put them in the Q&A or the chat.
If we can keep them to the chat, I think that will work better. We have a couple under review right here. I believe that there's been a couple questions about a recording, and we will send a recording out within the next 2 weeks, as you see here. There was a question that says that I'm interested in your thoughts on adding testosterone.
Great.
Great.
Yeah, great question. So I think the important things to know about testosterone is that there's no FDA-approved indication for of testosterone in women. However, testosterone can be used off-label, so I think it's important for people to know that it would be off-label use. But there have been a number of research studies, well-done research studies, that have shown that topical testosterone gel, when applied daily, it's applied, you squirt some out of the tube and you apply it to your thigh and you rub it in. It's every day. That has been studied pretty extensively in post-menopausal women for low libido. And so usually what I do is I'll start people on their systemic hormone therapy. I'll offer them the vaginal estrogen therapy because sometimes the reason there's a libido issue may be because they're having genital urinary syndrome of menopause, like we talked about. But if after doing those things, people still feel like they have low libido, it would be reasonable to have a discussion about testosterone gel in that situation.
Thank you,
That
Dr.
phone number
Schwang.
that's up right now is the virtual phone number. So if you want to make an appointment with the virtual clinic, that's the phone number. And Dr. Chuang is primarily running that, and I'm providing support for those of you who might decide an IUD is the right thing for you.
Dr. Schwang, do you mind moving back to the QR code and just putting that up for
Oh,
a couple
sure.
minutes? There seems to be some
Absolutely.
interest for that. And
Thank
then
you.
there's a question here. Is it normal to have hot flashes for over 9 years after having ovaries removed? Still has uterus and has been
Yeah.
told that not a candidate for hormone therapy.
Oh, I'm so sorry. Yeah, it's interesting. One of the slides that did not make it is this slide that kind of shows the trajectory of hot flashes. There are some really lucky women out there who have either no hot flashes or very minimal hot flashes. We love them. They're probably just like 10% of women. Most women are probably, if you look at averages, they probably have the most severe hot flashes sort of between a 5 and 8 year period. That's probably where most women fall. But there are some unlucky women who actually have um, lifelong hot flashes. They just never seem to dissipate. And we all know, we all have a couple of patients that fall in that category. And that is a risk benefit discussion of, actually, that's a good prompt to talk about how long is it safe to be on hormone therapy for. The guidelines used to recommend that we should really be on the lowest dose for the shortest amount of time. But in the most recent years, most recent guideline changes, that's been updated because there really is not, although the risk for certain adverse events do increase over time, there are going to be women who have hot flashes or other symptoms that are severe enough that when you look at the risk benefit ratio and they're having debilitating hot flashes, for them individually, it may still be worth continuing hormone therapy. So as long as we continue those conversations about the risks and the benefits, it can be very reasonable to continue hormone therapy well beyond 5 years and even well beyond 10 years.
But I think
But
that,
yeah, some women have them forever, I'm sorry to say.
and I think what Dr. Chuang just said was really important about individualizing care to each person. But for the typical amount of time that people stay on hormone therapy, if they're starting to feel better, then often people will start to some people will taper, some people will go cold turkey and kind of see, especially if they're on a really low dose to start with. But again, you can sort of taper these things up and down. I think more typical is that usually starting around 5 years, if things are looking a little bit better, we'll start to either taper or do a trial off. And so most people are on it for in that 5 to 10 year time frame. Most people don't continue beyond 10. And we usually would start to taper around 5. And then if it's not working well, again, we can kind of tinker for the individual, but that's the more typical course for the question in the chat there.
Can you speak to increased anxiety during perimenopause and how to manage it without medication?
Yeah, there are definitely increased report of mood and anxiety symptoms through menopause. Maybe a little bit different from mood, but people will describe brain fog as a very common symptom. Difficulty multitasking, but mood and kind of short temper. People will talk about how they feel like they just don't have the same amount of patience that they used to. It's harder to know how much of that is related to the hormone changes in menopause. I think that is an area that's still really under study. However, some people, and those are not outcomes that I think have been studied in some of these really big trials. There's some studies ongoing now to tell us more about that. I can anecdotally say that some people find that some of those symptoms improve when they're on hormone therapy. Other people don't. However, obviously we do have other ways to manage mood and anxiety symptoms as well. So I think one of the important things is for us to decide if there's other treatment options that we can think about besides hormone therapy.
I think that's where if you're open to medications, things like the SSRIs and SNRIs can sometimes be helpful for both depression and anxiety if some of those mood symptoms and lability are coming into play. If you're not open to medication, again, CBT, talk therapy, some of these things, some of these things are also just age and situation related, right? I've been having a lot of conversations in the last year or so, coming into this kind of age range myself, around being like the sandwich generation, right? And we're taking care of aging parents at the same time that we're still raising our own kids, and things like that. And so thinking about, if you're open to talk therapy, but you don't want to be on medications, sometimes managing all of those other things can also be helpful. And so some of that might be, as Dr. Chuang said, not well studied. Some of them might be attributable to the hormonal changes of menopause. Some of them might just be coincidental in that we're all, sort of managing life at the same time as we're going through all these changes. But if it works for you, it works for you. So if talk therapy, CBT can be helpful for those things as well, those are great tools that we have in our toolkit.
Melissa, I can try to do some quick hits here with some of the questions.
Sounds good.
There was a question about whether or not what about continuing estrogen therapy for a positive impact on bone density? Yeah, so I mentioned briefly that the estrogen therapy is FDA approved for prevention of osteoporosis. So I think if you're thinking about whether or not you should continue that, it's having that conversation. There are benefits for bone density. What are any risks involved? And as you get older, just weighing that risk-benefit ratio. There's a question about headaches during menstrual cycles. So we think about that as menstrually related headaches or menstrually related migraines. So a lot of people have migraines that are really associated with the menstrual cycle. And Dr. Horvath, probably one of the things you do commonly is help control people's menstrual cycle so that maybe their headaches may be less bothersome. It's hit or miss in menopause. Sometimes migraines get worse, but most of the time migraines get better during menopause. And sometimes there's ways that we can tailor your hormone therapy to maybe even help that as well. And then there was also a question, I just lost it, but there was a question about oh goodness, I forget. I'm sorry. I was scrolled by it and I don't see it anymore.
I'm also scrolling through some of the questions that we got in advance. Thank you so much, everybody, for this. Just like there are different things that we can do for you, I also want to point out that there are different vaginal moisturizers. There are different lubricants. Some of them are water-based. Some of them are silicone-based. You have different brands. And so the other thing is, if one of those isn't working for you, it doesn't mean they're all not working for you. So sometimes I have a lot of patients who will sort of play around and they'll be like, oh, I tried this one and it didn't really work, and we'll talk about it. Okay, oh, it was water-based. I know they're a little more expensive, try a silicone-based one. And then they do, and then that works for them. So people kind of play around and find the things that work and don't work. And so I think that's really important too, is taking that time. You're worth it. You're worth it. Take the time to figure out what works for you and do it.
There were a couple questions about cold flashes, and yes, we lump them, we call them hot flashes, but there are, and most women have hot flashes. What is a hot flash? It's this feeling of sensation of heat in your chest and face, but some people have cold flashes actually, and sometimes they're back to back, like you have the hot and then it's followed by cold. So what happens is our temperature regulation centers in our brain are regulated by estrogen, believe it or not. And so as we lose estrogen, that temperature regulation center can be out of whack. And so you can have both cold and hot flashes.
I think we're at time, but this has been a wonderful hour. Thank you for having me along on this journey, and thank you all for listening. Can we put the slide back up that has the phone number to call, just in case anybody wants to get in to Dr. Chuang's clinic?
And a couple of
And-
you are interested in seeing the slides, so you will get an email to the recording once that is all put together.
And Dr.
Dr.
Schwang, I
Schwang.
did want to just ask you if you could clarify. I think there were a couple of questions about what's needed about for making an appointment with the clinic, if there is a referral needed or anything like that. So just thought if you could clarify that before you go, that would be great.
Sure, great question. So no, you only just need to be self-referred. So if you feel like, I mean, I think my suggestion is if you already have a primary provider or a GYN provider, they may be very willing and able to have this conversation with you and talk with you about your hormone therapy or non-hormone therapy options. But if they're not and they want to refer you to me, or you can be self-referred. I actually don't need a referral. So you can just call the phone number and say, hey, I heard about the menopause clinic with Dr. Chuang. Can I make an appointment? My schedulers will make that appointment for you. You don't need to bring anything. I actually saw a question earlier, like, do I need what? I just need you to answer my questions and have a discussion with me. I don't need anything out of the ordinary. Melissa, should we wrap it up then?
Sure. Okay, perfect. Let's do that. Thank you, everyone. And thank you for your time and sharing all this news and information. We'll get the deck out here, like mentioned previously, within the next 2 weeks.
Thanks, everyone. I know it's late. It's late in the evening. Everyone has other things to do. And so thank you so much for spending this time with us.
Good night.
Bye.